Welcome to Chapter 3 of our discussion on the retina and vitreous. This lecture will provide an overview of retinal physiology with a focus on functional testing of the visual system. We will begin by reviewing the principles of electrophysiologic testing, including electro-retinography, electro-oculography, and visual evoked potentials, and how these modalities assess different levels of the visual pathway from the retinal pigment epithelium to the visual cortex. We will then discuss how to interpret these tests in clinical practice, including characteristic waveform patterns and their correlation with specific disease processes. In addition, we will cover complementary psychophysical tests, such as color vision testing, contrast sensitivity, and dark adaptometry, which assess integrated visual function and may detect abnormalities not captured by electrophysiology alone. Overall, this lecture will emphasize how these diagnostic tools are used together to localize dysfunction, guide clinical decision-making, and improve our understanding of retinal disease. Electrophysiological testing uses evoked potential techniques, in which controlled stimuli are applied to generate measurable electrophysiological responses. In this way, these tests provide an objective assessment of visual function. Importantly, this evaluation is not limited to a single structure, but instead spans the entire visual pathway. Specifically, electrophysiological testing assesses function from the level of the retinal pigment epithelium, or RPE, all the way through to the primary visual cortex, allowing for a comprehensive analysis of the visual system. The full-field ERG is used to measure generalized retinal function under both light-adapted and dark-adapted conditions. Beginning with the dark-adapted responses, the 0.01 weak flash primarily assesses the rod system, specifically reflecting on bipolar cell activity within the inner nuclear layer, and is the only test that selectively monitors rod function. Moving to the dark-adapted 3.0 standard flash, this produces a mixed rod-cone response, although it remains rod-dominant. With stronger stimuli, such as the dark-adapted 10.0 or 30.0 flashes, the response continues to represent a mixed rod-cone signal. In addition, oscillatory potentials can be evaluated, which primarily reflect amacrine cell signaling. Transitioning to light-adapted conditions, the light-adapted 3.0 flash assesses cone and bipolar cell function. Finally, the light-adapted 3.0 30 Hz flicker specifically evaluates generalized cone system function, providing a targeted measure of cone pathway activity. In addition to the full-field ERG, there are several other electrophysiologic tests that provide more targeted assessments of visual function. First, the multifocal ERG, or MFERG, evaluates cone system function over the central 40 to 50 degrees of the visual field, allowing for spatially localized analysis. Next, the pattern ERG, or PERG, specifically assesses macular retinal ganglion cell function, providing insight into inner retinal activity. In contrast, the electro-oculogram, or EOG, measures generalized retinal pigment epithelium function. Finally, the visual evoked potential, or VEP, extends beyond the retina to evaluate the function of the entire visual pathway, from the retina through to area V1 of the visual cortex.
ERGs provide objective measures of visual system function, making it a valuable tool in clinical assessment. However, these results must always be interpreted in conjunction with structural imaging, as normal structure does not necessarily imply normal function. In this context, ERG findings often correlate with the underlying pathophysiology, helping to clarify disease processes. Given this, ERGs have several important clinical applications. It can serve as a diagnostic tool, aid in monitoring disease progression, and help assess treatment efficacy. Additionally, it is used to provide outcome measures and safety indices in therapeutic interventions.
ERG provides an objective measure of retinal electrical activity that is triggered by a brief flash of light. To optimize testing conditions, the pupils are dilated to maximize retinal illumination, while the patient undergoes dark adaptation under dim red light. In terms of recording the electrical response, electrodes can be placed on the cornea or bulbar conjunctiva, or alternatively, skin electrodes may be positioned on the lower eyelids. There are several types of corneal electrodes, including contact lens, fiber, jet, and gold foil electrodes. Once the setup is complete, a series of stimuli are delivered under both dark-adapted and light-adapted conditions, and the resulting responses are recorded to assess retinal function.
The full field, or Ganzfeld ERG, uses a Ganzfeld bowl to provide uniform full retina illumination, creating a true full-field stimulus. Under these conditions, 6 standard responses are defined based on both the flash strength, measured in candela seconds per meter squared, and the adaptive state, either dark adapted or light adapted. As a result, the recorded signal produces a waveform characterized by an A wave and a B wave. Interpretation of this waveform focuses on its overall quality, specifically the amplitude, or size, and the timing of its components. In this context, the A wave represents a negative inflection and reflects photoreceptor function, while the B wave is a positive inflection and reflects bipolar cell function within the internuclear layer. This slide illustrates the basic full-field electroretinogram responses under different testing conditions. Beginning with the dark-adapted 0.01 response, this weak flash primarily isolates rod system function and is characterized by a B wave. As we increase the stimulus intensity to the dark-adapted 3.0 standard flash, we begin to see a mixed rod-cone response, with both an A wave and a B wave present, although the response remains rod-dominant. With the even stronger dark-adapted 10.0 flash, the mixed rod-cone response becomes more pronounced. In addition to these standard waveforms, oscillatory potentials are shown as small, high-frequency wavelets superimposed on the ascending limb of the B wave, reflecting inner retinal activity. Transitioning to light-adapted conditions, the light-adapted 3.0 response demonstrates cone and bipolar cell function, again with identifiable A and B waves. Finally, the light-adapted 3.0 flicker at 30 Hz produces a series of repetitive peaks, representing generalized cone system function under rapid stimulation.
Today we're going to look at the primary full-field ERG responses and read a patient's ERG. There are 4 primary ERG responses in the International Society for Electrophysiology of Vision, or ICEV, standard full-field ERG. 2 are performed under dim light and test rod function, and 2 are performed under bright light and test cone function. In reading a waveform, remember that the A wave is a negative deflection from the baseline to the trough of the wave. This is derived from the photoreceptors. The B wave is measured from the trough of the A wave to the peak of the next upward deflection, and this waveform is derived primarily from on-bipolar cells. To perform the full-field ERG, the patient's pupils are pharmacologically dilated, and the patient is then dark adapted for at least 20 minutes. The first response, shown here, uses a very dim light under scotopic conditions. This is the rod-specific response. We do not typically see an A wave here, but only a B wave. Now for all of these recordings, you will see the right eye on top and the left eye on the bottom. The next response, also under scotopic conditions, uses a very bright flash and measures both rod and cone function. It is sometimes called the combined response. Because there are approximately 20 times more rods than cones, it is a good measure of rod function and is typically referred to as the scotopic maximal flash. This will have an A wave and a B wave that should be larger than the A wave. The patient is then light adapted via the Ganzfeld bowl for 10 minutes. This bleaches the rods and renders them unable to respond to the next flashes. The first photopic response uses a bright flash and measures cone function. This is called the photopic single flash response. The second photopic response is the 30 Hz flicker. Only cones can respond at this flicker rate, and both amplitude and implicit time are usually reported with this response. So now let's go back to the beginning and read this ERG. To do this, I have obtained the microvolt values for the waveforms. I should say, when you refer a patient for an ERG, it's very helpful to provide as much information as possible. What are the patient's symptoms? What were the findings on exam and any imaging that was performed? In this case, the patient described difficulty seeing in dark conditions. The posterior pole exam was normal, as was spectral domain macular OCT and fundus autofluorescence. Okay, let's read this ERG. A full-field electroretinogram was performed according to ICEV standards. Rod-specific responses were 215 microvolts in the right eye and 305 microvolts in the left eye. The scotopic single-flash response in the right eye had an A wave of 405 microvolts and a B wave of 690 microvolts. In the left eye, the A wave was 390 microvolts and the B wave was 720 microvolts. Photopic single-flash responses were 185 microvolts in the right eye and 185 microvolts in the left eye. The 30 Hz flicker responses were 180 microvolts at 28.5 milliseconds in the right eye and 210 microvolts at 27 milliseconds in the left eye. These full-field recordings show no evidence of widespread retinal disease involving either the rod or cone system. There is no sign of an electronegative ERG. So, this ERG does not appear consistent with a rod-cone dystrophy and also does not display the characteristic electronegative ERG, that is, when the B wave is smaller than the A wave, of congenital stationary night blindness. I hope this was helpful. Thank you.
We're now going to discuss each individual condition of the full-field ERG. Starting with the dark-adapted 0.01 response, this represents a dim flash under scotopic conditions. This response primarily reflects rod system sensitivity, as the stimulus is too weak to activate the cone system. As a result, there is no A wave present, and the waveform is dominated by a B wave, which arises from on-bipolar cells located in the inner nuclear layer. Clinically, a reduced response in this setting indicates rod dysfunction. However, an important limitation to recognize is that this test cannot localize the dysfunction specifically to the photoreceptors versus the inner retina. Moving on to the dark-adapted 3.0 response, this represents the standard flash under scotopic conditions. In contrast to the dim flash, which only activates a rod response, this stimulus elicits a combined rod and cone response. As a result, the waveform now contains both an A wave and a B wave, reflecting contributions from photoreceptors and bipolar cells. Although both systems are involved, this response reflects mixed rod and cone function. Next, the dark-adapted 10.0 or 30.0 responses represent bright flash stimuli under scotopic conditions. Similar to the standard flash, these responses reflect mixed rod and cone function. However, with increased stimulus intensity, the A wave becomes more prominent and more easily measurable. Because of this, the majority of the response at these higher intensities reflects photoreceptor function. This feature makes the bright flash ERG particularly useful for localizing dysfunction within the retina. For example, a reduced dark-adapted 0.01 response in combination with a decreased A wave on the 10.0 or 30.0 response suggests photoreceptor dysfunction. In contrast, a normal A wave with a reduced B wave, producing an electronegative ERG, indicates inner retinal dysfunction occurring after phototransduction. In addition to the standard ERG waveforms, oscillatory potentials are small oscillations that occur on the ascending limb of the B wave. These wavelets originate largely from amacrine cell activity within the inner retina. Clinically, these oscillatory potentials can be reduced in certain conditions, including retinal ischemia and congenital stationary night blindness. However, despite their physiologic significance, it is important to note that they have limited diagnostic value. Transitioning now to light-adapted testing. The light-adapted 3.0 response represents the standard flash under photopic conditions. In this setting, the test measures cone function only, as light adaptation saturates the rod system and suppresses its ability to respond. The resulting waveform includes both an A wave and a B wave. The A wave reflects activity from cone photoreceptors, as well as off-bipolar cells, while the B wave represents contributions from both on and off bipolar cells. Because this response isolates cone pathway activity, it is particularly useful for localizing dysfunction to the cone system.
For the flicker ERG, we're looking at the LA 3.0 30 Hz response, which means this is a light-adapted 30 Hz flicker stimulus. The key point is that this response is primarily testing the cone system. Rods do not contribute meaningfully here because they have relatively poor temporal resolution and cannot follow a rapidly flickering stimulus at 30 Hz. Clinically, this is a sensitive test for cone dysfunction, but it is not anatomically specific. In other words, an abnormal 30 Hz flicker tells you there is cone system dysfunction, but it does not localize the problem to a specific retinal layer or disease process. The two main features to pay attention to are timing and amplitude. If the peak time is delayed, that suggests more generalized cone dysfunction. If the amplitude is reduced but the peak time remains normal, that suggests a more restricted loss of cone function, where fewer cones are contributing but the remaining cone responses are still timed appropriately.
Finally, several physiologic and technical factors can influence ERG responses and should be considered during interpretation. First, pupil size affects the recorded response, so it is important to measure it at the start of testing. In addition, ERG amplitude declines with age, which is why comparisons should be made using age-matched controls. In newborns, ERG responses are smaller and more simplified, but they mature to adult values within the first year of life. Furthermore, ERG responses are relatively insensitive to refractive error. For example, in high myopia, there may be a decrease in amplitude, but without a delay in peak time, as would be seen in inherited retinal degenerations. Lastly, ERG is minimally affected by media opacity, such as cataract or vitreous hemorrhage, making it a useful tool even in the presence of these conditions.
When interpreting ERG results, certain characteristic patterns can help guide diagnosis. First, a delay in peak time is typically associated with generalized dysfunction of the retina. In contrast, a reduction in amplitude suggests more localized or restricted dysfunction. Examples of this pattern include conditions such as partial retinal detachment, branch vascular occlusion, regional uveitis, and sector retinitis pigmentosa. In addition, the 30 Hz flicker peak time is particularly useful for assessing timing abnormalities. This becomes especially relevant in inflammatory disease, such as posterior uveitis. In these cases, there may be a delay in timing with relatively preserved amplitude. More specifically, a marked delay in the 30 Hz flicker response combined with high amplitude suggests an inflammatory etiology.
In clinical practice, the full-field ERG reflects the mass response of the entire retina. Because of this, it may remain normal in diseases confined to the macula, as the macula contributes minimally to the full-field signal, with most cones located extramacularly. In contrast, an abnormal photopic ERG suggests cone dysfunction outside the macula. This distinction is particularly helpful when differentiating disease patterns. For example, macular dystrophies typically have a normal full-field ERG, whereas cone or cone rod dystrophies demonstrate an abnormal ERG, often with greater visual implications. As a specific example, ABCA4 retinopathy, including Stargardt disease and fundus flavimaculatus, can show severe generalized cone and rod dysfunction. However, if the full-field ERG is normal at presentation, this suggests that dysfunction is confined to the macula. In these cases, prognosis is relatively favorable, with approximately 80% of patients retaining a normal full-field ERG at 10 years. This slide summarizes characteristic ERG patterns seen across different retinal pathologies, allowing for comparison of responses under multiple testing conditions, including dark-adapted, light-adapted, and flicker responses, as well as pattern ERG. Starting with the normal pattern, all waveforms demonstrate expected amplitudes and timing, with intact responses across rod and cone-mediated conditions, and a normal PERG. In macular dystrophy, the full-field ERG responses remain normal, reflecting preserved global retinal function, while the PERG is abnormal or undetectable, indicating macular involvement. In cone dystrophy, dark-adapted responses are preserved, but light-adapted and 30 Hz flicker responses are reduced and delayed, consistent with cone system dysfunction. The PERG is also subnormal, reflecting macular involvement. In rod cone dystrophy, such as retinitis pigmentosa with macular involvement, there is marked reduction across all ERG responses, with rod responses affected earlier. The A wave in the dark-adapted 10.0 response is severely reduced, indicating photoreceptor dysfunction, and there is delay in cone-mediated responses. The PERG is abnormal, consistent with macular involvement.
Finally, in rod cone dystrophy with macular sparing, the full-field ERG shows a similar abnormal rod cone pattern, but the PERG remains normal, indicating preserved macular function despite widespread retinal disease.
This slide highlights additional ERG pathology patterns, focusing on specific inherited and functional retinal disorders and their characteristic waveform findings across different testing conditions. Beginning with complete congenital stationary night blindness, or CCSNB, the PERG response demonstrates macular sparing. The dark-adapted 0.01 response is undetectable, while the dark-adapted 10.0 response is electronegative, with a normal A wave and a markedly reduced B wave, indicating inner retinal dysfunction. The 30 Hz flicker shows only minor changes in waveform and delay, and the light-adapted 3.0 response demonstrates loss of the cone-on pathway with sparing of the off pathway. In contrast, incomplete congenital stationary night blindness, or ICSNB, shows a subnormal but detectable dark-adapted 0.01 response. The dark-adapted 10.0 response is also electronegative, and the 30 Hz flicker demonstrates markedly subnormal amplitude and a characteristic triphasic waveform. The light-adapted 3.0 response shows both a subnormal A wave and a markedly reduced B wave, reflecting involvement of both on and off cone pathways, and the PERG is subnormal. Moving to X-linked retinoschisis, or XLRS, the dark-adapted 0.01 response is severely reduced, and the dark-adapted 10.0 response is profoundly electronegative. The 30 Hz flicker shows delay, and the light-adapted 3.0 response demonstrates both delay and a reduced B wave to A wave ratio. The PERG is also markedly subnormal. Finally, in blue cone monochromacy, or BCM, the dark-adapted 0.01 and 10.0 responses are normal. However, the 30 Hz flicker responses are virtually undetectable, and the light-adapted 3.0 response shows only a small B wave at approximately 50 milliseconds, consistent with an S-cone origin. The PERG response in this condition is undetectable.
The multifocal ERG, or MFERG, produces a topographic map of central cone function, allowing for localized assessment of retinal activity. In this way, it is particularly useful for evaluating the spatial distribution of macular dysfunction. The stimulus used in MFERG consists of multiple hexagonal elements, which are smaller centrally than in the periphery, reflecting the higher cone density in the macula. These elements are presented in a pseudo-random sequence of flashes across a field size of approximately 40 to 50 degrees. Using cross-correlation techniques, the recorded signals are then analyzed to derive small ERG waveforms corresponding to each individual hexagon, enabling detailed mapping of retinal function across the central visual field.
Focusing now on MFERG waveform components, the response is characterized by a series of distinct deflections. The N1 component represents the initial negative deflection and arises from cone photoreceptors and cone bipolar cells, making it analogous to the light-adapted A wave. Following this, the P1 component is the primary positive peak of the waveform. This is then succeeded by the N2 component, which is a second negative deflection. Importantly, the P1 and N2 components are generated by cells that contribute to the light-adapted B wave and oscillatory potentials, reflecting inner retinal activity within the cone pathway. This pattern is depicted in the top figure. The lower right figure shows a multifocal ERG map in a patient with Stargardt's disease. Each small waveform represents the response from an individual hexagonal region of the retina. There is a clear central area of reduced or abnormal responses, outlined by the dashed circle, indicating localized macular dysfunction. The surrounding peripheral responses are relatively preserved, demonstrating how MFERG can spatially localize retinal abnormalities.
The multifocal ERG also has several important clinical uses, particularly in the evaluation of macular and parafoveal function. Compared to pattern ERG, it is less sensitive for detecting cystoid macular edema, but it still provides valuable complementary information when used alongside PERG. In addition, MFERG is commonly used in the assessment of hydroxychloroquine toxicity. In this setting, a characteristic pattern can be seen, with relative central sparing and parafoveal loss, often described as a ring pattern. Quantitative approaches, such as ring analysis, may further enhance detection. However, it is important to recognize a limitation of MFERG, as it may miss extramacular damage. This is particularly relevant in certain populations, such as Asian patients, where toxicity may occur outside the central testing field.
The pattern ERG, or PERG, is designed to capture macular function in response to an isoluminant pattern reversal stimulus, typically a checkerboard.
Because the stimulus is isoluminate, this test measures contrast rather than overall luminance, making it particularly sensitive to macular and ganglion cell activity. In this setup, the image is focused on the macula, and responses are recorded using non-corneal electrodes. Given that the resulting signals are relatively small, signal averaging is required to obtain a reliable waveform. The PERG waveform consists of two main components. The N95 component reflects retinal ganglion cell function and is therefore a measure of central RGC activity. In contrast, the P50 component represents combined input from macular photoreceptors and retinal ganglion cells, serving as a broader indicator of macular function. Clinically, PERG is useful in helping to interpret visual evoked potential results and is particularly valuable for detecting ganglion cell disease, such as dominant optic atrophy and Leber hereditary optic neuropathy. Electroretinography serves as an objective measure for the diagnosis, management, and follow-up of retinal disease. Because it provides quantitative functional data, it can help guide treatment decisions and monitor response to therapy over time. In addition, ERG is particularly useful for detecting early drug-related retinal toxicity, often before structural changes become apparent. Beyond this, ERG can help distinguish between different pathologies based on presenting symptoms. For example, in patients with nyctalopia, rod cone dystrophy is associated with an abnormal dark-adapted A wave, whereas congenital stationary night blindness shows a normal A wave with an electronegative ERG. In patients with photophobia, findings point toward cone dysfunction. Similarly, symptoms of photopsia or shimmering raise concern for autoimmune, including paraneoplastic retinopathy. Finally, ERG is also useful in the evaluation of inflammatory retinal disease, such as birdshot chorioretinopathy, where it can provide functional insight into disease activity. When interpreting ERG findings, there are a few rare conditions in which the results can be considered pathognomonic. These include bradyopsia, associated with RGS9 or R9AP mutations, enhanced S-cone syndrome, associated with NR2E3 mutations, and cone dystrophy with supernormal rod ERG, associated with KCNV2 mutations. Outside of these specific entities, however, ERG results must always be interpreted within the broader clinical context. ERG is also particularly useful in the evaluation of vascular disease. In central retinal artery occlusion, or CRAO, the ERG demonstrates a negative waveform, where the B wave amplitude is smaller than the A wave. This reflects the underlying physiology, in which photoreceptors are supplied by the choroidal circulation and remain relatively preserved, while the internuclear layer, including bipolar cells supplied by the central retinal artery, is compromised. As a result, the A wave is preserved while the B wave is attenuated. In central vein retinal occlusion, or CRVO, ERG may also show a negative waveform or a delay in the 30 Hz flicker response, reflecting ischemia affecting inner retinal function.
This slide highlights some of the important clinical applications of ERG testing, especially in carrier detection and pediatric retinal disease. One major use is identifying carriers of inherited retinal disorders. In X-linked retinitis pigmentosa, female carriers can sometimes have a relatively normal-looking fundus exam but still demonstrate an abnormal ERG. This occurs because of lionization, also called random X chromosome inactivation. Normally, females have two X chromosomes, but early in embryological development, each cell randomly inactivates one X chromosome. As a result, some retinal cells express the normal gene while others express the mutated gene. This creates a mosaic pattern of retinal function. Even if the fundus appears relatively normal, enough dysfunctional photoreceptors may be present to produce measurable ERG abnormalities. By contrast, carriers of choroideremia may show obvious patchy fundus changes because of this same mosaic expression pattern, yet still maintain a relatively normal ERG if enough retinal tissue remains functional overall. So in choroideremia carriers, the structural appearance can look abnormal while global retinal function remains preserved. ERG is also particularly useful in pediatrics because it can be performed at essentially any age, including infancy. Retinal responses mature fairly quickly, and ERG amplitudes and timing typically reach near adult values by around 6 to 9 months of age. One important practical consideration is anesthesia. Sedation or general anesthesia can alter retinal responsiveness and reduce ERG sensitivity, so interpretation should always take the testing conditions into account.
Electro-oculography, or EOG, is used to assess retinal pigment epithelium function and its interaction with photoreceptors by measuring the corneoretinal standing potential under both dark and light-adapted conditions. This standing potential reflects the voltage differential across the RPE, providing an indirect measure of its function.
At a cellular level, chloride channels are abundant within the RPE, and abnormalities in these channels, such as in Best dystrophy, are associated with abnormal EOG findings. In terms of protocol, the patient fixates alternatively on two targets positioned approximately 30 degrees apart, holding fixation for about 10 seconds each minute. The test is performed over approximately 15 minutes of dark adaptation, followed by about 12 minutes of light adaptation. During this time, the amplitude of the signal is recorded using electrodes placed at the medial and lateral canthi. Key parameters include the dark trough, which occurs at around 12 minutes of dark adaptation, and the light peak, which occurs at approximately 8 minutes of light adaptation. The Arden ratio, defined as the light peak divided by the dark trough, is then calculated. A normal Arden ratio is greater than 170% and requires intact photoreceptor and RPE function.
This slide illustrates both the setup and the characteristic response pattern of EOGs. On the left, the figure demonstrates the testing configuration. Electrodes are placed near the medial and lateral canthi, and the patient is instructed to alternate fixation between two targets positioned approximately 30 degrees apart, shown here as about 15 degrees to each side of center. As the eyes move back and forth between these targets, the measured voltage changes in proportion to the corneo-retinal standing potential, generating a step-like or square wave signal. On the right, the graph depicts how this standing potential changes over time during the test. During the dark adapted phase, labeled lights out, the signal gradually decreases to a minimum, known as the dark trough. After the lights are turned on, during the light adapted phase, the potential rises to a maximum, known as the light peak. The repeated oscillations shown on the curve correspond to the patient's alternating eye movements during fixation. Clinically, the relationship between these two values, the light peak and the dark trough, is used to calculate the Arden ratio, which serves as the key quantitative measure of RPE function.
EOG findings are abnormal in any condition involving rod photoreceptor dysfunction, such as retinitis pigmentosa, reflecting the dependence of the RPE photoreceptor complex on normal rod activity. In terms of key clinical uses, EOG is particularly important in Best 1-related disease, or Best disease, where there is a decreased or absent light rise despite a normal full-field ERG. This dissociation is a classic feature and highlights primary RPE dysfunction. In autosomal recessive bestrophinopathy, there is a marked reduction in the light rise. In this condition, the full-field ERG may be abnormal, but the degree of ERG abnormality is not proportional to the EOG findings. Importantly, carriers do not demonstrate EOG abnormalities. In adult vitelliform dystrophy, the EOG is typically only mildly subnormal. Additionally, EOG can be used in the diagnosis of Azor. The figures on the right illustrate these differences. The normal EOG tracings show a clear increase in amplitude from the dark phase to the light phase, representing a normal light rise and resulting in a normal Arden ratio. In contrast, the tracings labeled Best disease show an absent or markedly blunted light rise with minimal change between dark and light conditions, corresponding to a reduced Arden ratio.
Visual evoked potentials, or VEPs, measure the cortical electrical response to retinal stimulation, providing an assessment of the visual pathway up to the occipital cortex. These responses can be elicited using either flash stimuli or pattern stimuli, such as a checkerboard, and are recorded via electrodes placed over the occipital scalp. Pattern reversal VEPs produce relatively consistent waveforms across individuals, with stable timing but variable amplitude, making latency a particularly reliable parameter. In contrast, flash VEPs are more variable across a population, but are useful for comparing responses between the two eyes or between hemispheres within the same patient. A key feature of the VEP waveform is the P100, a positive deflection occurring at approximately 100 milliseconds. This component is analyzed based on both its amplitude and latency. In the figure, the waveform demonstrates this characteristic P100 peak, followed by a subsequent negative deflection, labeled N135, illustrating the typical morphology of a VEP tracing. VEPs have several important clinical applications, primarily in assessing optic nerve function. They are particularly useful for detecting conduction delays, as seen in demyelinating optic neuritis, such as in multiple sclerosis. However, while delays are common in optic nerve disease, they are not specific to a single diagnosis. Abnormalities on VEP can present in different ways, including increased latency or asymmetry in amplitude between the two eyes.
as may be seen in conditions like non-arteritic anterior ischemic optic neuropathy. It is also important to recognize that macular disease can affect VEP results, so findings should be correlated with MFERG or PERG when appropriate. In addition, VEP is useful in evaluating non-organic vision loss, as it can demonstrate intact visual pathway function despite reported visual deficits. The figure on the right illustrates a pattern reversal VEP comparing the right and left eyes. The left eye shows a normal P100 response with expected timing. In contrast, the right eye demonstrates a delayed P100 latency, while maintaining relatively preserved amplitude and waveform shape, a pattern consistent with optic nerve conduction delay. VEPs also have several important special uses, particularly in pediatric populations. In children, VEP is essential in evaluating pre-verbal patients, as well as those with nystagmus or unexplained vision loss, where subjective testing is limited. One specific modality, the pattern appearance VEP, is particularly useful in conditions such as albinism, where it can help detect misrouting of the visual pathways. Additionally, this technique is less affected by nystagmus, making it advantageous in patients with unstable fixation. Flash VEP also plays a key role, especially in infants with poor fixation, as it does not require precise visual focus. Finally, VEP can be used to assess visual system resolution, serving as a surrogate measure for visual acuity when standard testing cannot be performed. Microperimetry is a specialized visual field test that combines computerized threshold perimetry with real-time retinal imaging, allowing for precise functional assessment mapped directly onto retinal anatomy. In this technique, the patient's response to light stimuli is measured at specific retinal locations, and these data points are overlaid onto a retinal image, such as from scanning laser ophthalmoscopy or fundus photography. This approach enables identification of areas with decreased retinal sensitivity and localized functional defects. Importantly, retinal tracking technology continuously monitors eye movements in real time, allowing the system to adjust for fixation changes and maintain accurate stimulus placement. Because of this precise structure-function correlation, microperimetry is particularly useful for assessing residual visual function in patients with macular disease. Psychophysical testing provides a complementary approach to electrophysiology in evaluating visual function. Electrophysiologic tests are objective and can assess layer-specific function within the visual system, but they are limited in detecting small or localized defects. In contrast, psychophysical tests are highly sensitive but inherently subjective as they rely on patient responses. These tests do not localize dysfunction to a specific level of the visual pathway. Instead, they reflect the integrated visual perception of the entire system. Common types of psychophysical testing include visual acuity, visual field testing, color vision assessment, contrast sensitivity, and dark adaptation, each providing different aspects of functional visual performance. Color vision is mediated by three types of cone photoreceptors. These include the S cones, which are sensitive to short wavelengths and correspond to blue light, the M cones, which respond to medium wavelengths and correspond to green light, and the L cones, which detect long wavelengths and correspond to red light. The visual system is organized to detect contrast between these cone inputs, specifically along red versus green and blue versus yellow axes. Based on this contrast processing physiology, color vision deficiencies can be understood in terms of disruptions in these pathways. Red-green deficiencies are the most common and are typically X-linked, affecting approximately 5 to 8% of males. Within this category, protan defects involve the L cones, while deutan defects involve the M cones. It is important to note that these deficiencies may not always reflect simple single-gene defects. In contrast, blue-yellow deficiencies are rarely inherited and, when present, may be indicative of acquired disease. Testing of color vision can be performed using the anomaloscope, which is considered the gold standard. This test is most accurate for detecting congenital red-green color deficiencies, although it is not widely used in routine clinical practice. During the test, the patient adjusts a toggle bar to match the color of two adjacent halves of a circular field. By altering the proportion of red and green light, the patient attempts to achieve a perceptual color match between the two sides. If they are a perfect match, they will select Match. Otherwise, they can select No Match Possible.
An abnormal result, indicating a color deficiency, occurs when the patient cannot appropriately identify a match despite there being one, or selecting that there is no match when indeed there is. The figures at the bottom illustrate this process. Each image shows a split circular field where the patient adjusts the slider to make both halves appear identical in color. One example demonstrates a successful match, while the other represents a mismatch, highlighting how differences in color perception are identified during testing. Pseudo-isochromatic plate tests are the most commonly used methods for color vision screening. These tests are performed under daylight-like illumination to ensure accurate color perception during evaluation. The most widely used plates are the Ishihara plates, which are designed to test the protan, or red, and deutan, or green axes. These plates consist of colored dots forming numbers or patterns that are visible only if color vision is intact along these pathways. In addition, the Hardy-Rand-Rittler, or HRR, plates extend this testing by also assessing the tritan, or blue-yellow axis, allowing for detection of a broader range of color vision deficiencies. The figures on the right illustrate examples of these tests. The Ishihara plate shows a number embedded within a field of colored dots, which can be identified by individuals with normal red-green color vision. The HRR plate, in contrast, uses shapes such as circles and crosses to detect abnormalities, including those affecting the blue-yellow axis. Pseudo-isochromatic plate tests are based on specific visual principles designed to detect color vision deficiencies. These tests present colored numbers or figures embedded within a background of colored dots. The colors are carefully selected so that they are difficult to distinguish for individuals with color vision deficiencies. As a result, patients with defective color vision may either be unable to perceive the intended pattern or may instead see an alternative pattern based on brightness differences rather than true color discrimination. In terms of limitations, these tests are quick and highly sensitive, making them useful for screening purposes. However, they are not effective for accurately classifying the specific type or severity of color vision deficiency. Farnsworth color vision testing provides a more detailed assessment of hue discrimination compared to screening tests. The Farnsworth-Munsell 100 hue test is highly sensitive and can detect very subtle differences in hue on the order of 1 to 4 nanometers. In this test, the patient arranges 4 sets of 25 colored tablets in order based on slight shade differences. Although it is time-consuming, it is particularly useful for identifying mild defects in hue discrimination. A more practical alternative for clinical use is the Farnsworth panel D15 test. This test uses 15 colored tablets that the patient arranges in sequence according to hue, making it faster and more feasible in routine settings. The pattern of errors can then be plotted to determine the type of color vision deficiency, including distinguishing between congenital and acquired causes, as well as identifying protan, deutan, or tritan axis defects. In terms of features, the D15 test may miss mild defects, but is useful for assessing the functional significance of a color vision abnormality. For example, a patient who fails Ishihara testing but passes the D15 likely has minimal real-world impairment. Variants of the test include desaturated versions, such as the Lanthony D15, which are more sensitive to subtle defects, as well as enlarged versions designed for patients with reduced visual acuity. Testing of contrast sensitivity evaluates how well a patient can detect differences between light and dark, which is often related to spatial frequency, or the size of alternating light-dark cycles. The visual system demonstrates peak sensitivity at approximately 2 to 5 cycles per degree. One commonly used method is the Pelley-Robson test. This test uses a single large letter size, approximately equivalent to 2060, so that performance depends primarily on contrast rather than resolution. As the patient reads down the chart, contrast decreases from top to bottom, and within each line, contrast also decreases from left to right. The patient continues reading until they are unable to correctly identify at least 2 out of 3 letters in a group. The final score is determined by the last group of letters read correctly. In terms of interpretation, a score of around 2.0 corresponds to normal contrast sensitivity, or approximately 100%. Scores below 1.5 indicate visual impairment, and scores below 1.0 are consistent with visual disability. The figure on the right illustrates this progressive reduction in contrast, with letters becoming increasingly faint as testing proceeds.
Contrast sensitivity is an important aspect of visual function that is not fully captured by standard visual acuity testing. A loss of contrast sensitivity can result in visual dysfunction that is disproportionate to measured visual acuity. As a result, patients may have relatively good visual acuity, such as 20/30 or better, yet still experience poor functional vision. Clinically, this can manifest as difficulty with tasks such as reading or navigation, particularly in low-contrast environments. This limitation highlights an important shortcoming of Snellen visual acuity testing, which measures only high-contrast stimuli and does not assess more subtle aspects of light perception. In everyday vision, contrast plays a critical role in detecting light-dark differences. When contrast is reduced, such as in conditions like dusk or fog, object recognition becomes more difficult. Similarly, decreased contrast sensitivity due to retinal diseases, such as age-related macular degeneration or diabetic macular edema, or from media opacities, can significantly impair overall visual function. Dark adaptometry evaluates the eye's ability to adjust to low light conditions, with overall sensitivity spanning approximately 10 to 11 log units. This test measures the absolute thresholds of both rod and cone systems, providing a functional assessment of photoreceptor sensitivity during dark adaptation. Traditionally, this is measured using the Goldman-Wiekers adaptometer, although this instrument is not widely available in current clinical practice, despite much of the literature being based on it. Clinically, dark adaptometry is particularly useful in patients with nyctalopia, as it directly assesses rod-mediated vision. It is a subjective test and is best interpreted alongside electrophysiologic studies such as ERG. As a focal test, it can also help identify localized retinal dysfunction, and in some cases, may be more sensitive than ERG in detecting early disease. Congratulations on finishing this chapter. In summary, retinal physiology can be evaluated through a combination of electrophysiologic and psychophysical testing, each providing complementary insights into visual function. Understanding how to interpret these modalities together allows for more precise localization of disease, earlier detection of dysfunction, and better informed clinical decision-making. Ultimately, integrating these tools into practice enhances our ability to diagnose, monitor, and manage a wide range of retinal and visual pathway disorders. Great job! We'll see you in the next chapter.